Welcome to Field Notes, Insights from New to Public Health Alumni. New to Public Health is a year-long workforce training program for those who are new into the field of public health. I'm Juliana Mansky.
And I'm Mackenzie Legal. We are program facilitators and hosts of this podcast. With a vibrant community of over 400 current and past residents, New to Public Health is a wealth of knowledge and experience in the public health field.
In each episode, we'll share inspiring stories and valuable insights from those who've journeyed into public health, highlighting their unique path and the impact they're making. Joining us today is Alyssa Knoll, licensed clinical social worker and community engagement and partnership coordinator for the Suicide Prevention Program at the Oscar G. Johnson Veterans Affairs Medical Center in Iron Mountain, Michigan. Alyssa graduated from the New to Public Health Residency Program in November 2022. Alyssa, thanks so much for being with us today. Would you start by telling us more about your role?
Yes, thank you so much for having me. I'm excited to be here. So, this program, the CEPC or Community Engagement and Partnership Program role started as a pilot program, I think about 4 or 5 years ago in Minnesota, actually, and has now spread across the entire nation. And initially, the VA, the CDC, and I believe SAMHSA also got together and had a high-level national discussion about how do we nationally impact veteran suicide. And from that conversation, the CEPC role was born, along with some other initiatives that people might be familiar with. The Governor's Challenge. So each state, the governors were challenged to come up with a veteran coalition that was focused on suicide prevention. And some very rural communities have a program called Together with Veterans that was also a strategy that came from that same conversation. And the priorities for the VA then for the CEPC program coincide with the CDC strategies. There's a lot of complement. And so the strategies for the VA are identify service members, veterans, their families, and screen for suicide risk. The CDC has some similar strengthen access and delivery of suicide care and identify support people at risk. And so there's some similarities in the wording. Another priority for the VA CEPC program is to promote connectedness and improve care transitions for veterans and service members. What we have found is that as a service member who's active or in the Guard or Reserve is transitioning from their service into veteran status, they've gone from a very, potentially as an active duty member, a very routine life where they've got housing on base, they've got everything kind of mapped out for them, and now they're in the community, potentially away from family. There's a lot to pick up and start figuring out for themselves that has been taken care of and has been mapped out for them as far as where they're going to live. They've gotten orders. They've been told where to, this is where you're going to live for 4 years. This is the base you'll be at. And now they can kind of go anywhere and do anything. And so there's a lot of choices and decisions to be made. And in that transition, there can be a lot of their identity is changing. They're choosing a job for themselves. They're trying to figure out how does what I've been doing and the purpose and meaning I've had in my life change. This transition, the improving care and transition can mean retirement. It can mean transitioning from being single to being a family. It can be anything. So promoting connectedness can mean healthcare access. It can be how are you getting connected to each other, to yourself? Anything that's really promoting that protective factor in a community and reducing suicide. And then increasing lethal means safety and safety planning is our third priority area. Increasing lethal means is so important. That safety piece, we're really looking at how do we reduce time from the point where someone has made a decision to die by suicide and their choice of means. In that time frame, there's an opportunity to intervene, there's an opportunity for someone to interrupt, there's a chance for them to reach out for help. And we know that close to 90% of veterans have a firearm in their home. And nationally speaking, over 60% of people are choosing firearms as a way to die by suicide. So that puts our veterans at very high risk, and also the people in their home who are struggling with mental health at high risk. So talking about how do we create safety for those, it's not about taking that firearm away, but if you have someone in your home struggling, how do we keep you safe for that time being? How do we create that planning strategy so that everyone in the home is safe if they're having a hard time for a short period of time? And creating that plan with each other, that family plan with each other. So those are the three strategies that the VA came up with. And they said, okay, CEPCs, we really want you to go out into the community. And that's where the public health strategy really came into play. They were already very clinically based internally within the VA. We have suicide prevention coordinators, we have our therapists, and there's a lot of programming within the VA that if a veteran is enrolled, they are getting screened for suicide. They're identified by coming in, that they're a veteran, that they are there for help. And so if they have trouble, there's people there that they can go to. They're established in some kind of care, and there's people that they can talk to. There's groups that they can reach out to. There's things that they can participate in. Where out in the community as a veteran, we were finding that the suicide rates weren't decreasing as much as the veterans who were enrolled in care were. And so the VA said, how do we start to share some of the things that are working internally in the VA out to the community? So the CEPC role became part of that mission to reduce suicide in the community. So they said, okay, we have this community-based idea. We're going to add that to what's already happening internally in the VA, the clinical-based piece. And that's going to create our full public health model. We're really going to look at all veterans, the full population of veterans. How do we reduce suicide? Looking at the full population. And one of the tenets of the VA has always been, suicide is preventable and we want to get to zero suicides. Well, previously, before this public health approach, they weren't really addressing the needs of all veterans by only focusing on VA enrolled veterans. Now the VA is really looking at the full population and offering this liaison in the role of a CEPC out into the community really gives them that arm to say, we're offering technical assistance to coalitions, we're offering resources to the community. We're really trying to get in touch with all veterans to really provide suicide prevention in an effort to get to zero suicides. So it's a unique and new approach for the VA to get outside the walls of the VA and really try to do some work. So I'm excited about that and to be part of that.
That is really exciting. And having that public health approach, it sounds like the VA is really moving forward to connect with veterans, hear their lived experience, and get their opinion on and thoughts on this model too, to say, hey, what do you need? What are, what will work for you? Where are you? And how can we meet you where you are at? So tell me a little more about how that like team integration and coordination is happening.
Thank you for asking that. I think that's probably the most exciting part of my job. That's exactly the feedback that my role gets to go out and ask for. Um, and it's it's really fun to be out in the community and be getting to learn so much about the area that I live in and the people. Um, Part of it comes from being at events and getting that face to face where people are coming to resource fairs and they're coming and telling me their personal stories and what they're looking for. So some of that happens on an individual basis, and I get to hear directly from veterans and their spouses and their family members. Sometimes it's from people who have lost a loved one to suicide. And it comes in the form of offering some support and connection that way. That's never an easy way to hear the story. That's always the story that we hope we're trying to prevent, obviously. But there's a lot to learn from those stories too. Then there's the community level, right? Where we're looking at how do we start to create a safety net for everybody in the community? Because as we do that, we are also creating a safety net for veterans. When we have a safety net in the community and we're lifting everyone up to a safe place and creating protective factors for everyone, we are also protecting veterans and their spouses and their families. And that's important. And we know that that's important to veterans, that they want their families to be safe too. And that's something that we've heard from them. And so that is where the coalitions come into play. I'm a part of a lot of mental health coalitions, and they're doing community health assessments and they're getting surveys out there and they're hearing from the community, and we're getting data back about how do you want to learn about suicide prevention? Where do you want to hear about it? Who do you want to hear about it from? How are you struggling with mental health? How many of you have had suicidal thoughts? We're asking questions about stigma and getting a real sense of what is the belief system and the culture around suicide prevention and substance use in the communities, to figure out where does the education and the training need to be done to continue to help people feel comfortable in their communities, and what kinds of discussions need to happen. And hopefully between those two interactions, that individual level and that community level, we're doing the things that can be helpful to the community to make that societal change long term. And that piece, and this is the part that gets me excited about the New to Public Health program. I believe my being in that program is what helped me to understand how those pieces come together to really make change. And that's what I get super excited about, because before, when I was brand new to public health. I was brand new to this position, and I went to my boss and I'm like, I'm not wrapping my head around this public health piece. Like, I get it. I get it that it's the community, and I get that my experience is in individual therapy and I need to broaden my brain out and figure this out, but I'm missing something. I need more information, and he was on board and supportive of me taking the new to public health class, and that was pivotal for me, because after taking the class, not only have I been able to really talk to health departments and these coalitions and have a better understanding of CHAs and CHIPs, but it's given me the ability to see how we can impact change in communities and have these discussions. And now I'm seeing it play out in front of me. And I just get so excited seeing all the pieces now fall into place. So having had the class, laid the groundwork, had the conversations with, coalitions and with veterans, and been able to take that information, make it part of action plans, and now seeing those action plans playing out and seeing the change happening in the communities is so powerful. And that would not have happened for me in this position. And it would have happened. The community would have been able to do those things without me and without, there are very smart individuals in our communities doing this work, and the health departments are very capable, but I would have missed out on key pieces of this had I not taken the class. And so I'm excited that the class allowed me to be part of these conversations and have an understanding of how it all fits together and be a key part of those conversations to get these coalitions and be part of these conversations to get to where they are today and be able to see the change happening. And I give a lot of credit to being in that class.
Oh, thank you, Alyssa. That's so nice to hear and so heartwarming. And that's exactly the intent that we hope residents who go through and graduate from the program have, is be able to get that full picture of public health, pull in the pieces and see how they fit, and also kind of open your eyes and work to how you fit within there, but how everyone also works together, and just create that network to know how and who to approach and
Yeah,
see.
exactly.
Think outside the box a little bit on who those community partners are. And that really is the public health approach to build your capacity, and how can everyone work together and also know all of the special populations that we need to be thinking about, and have that specific approach when we are trying to connect with a certain group of people. So I'm so glad that you're able to apply all those skills from the program into your work. And it is clear that you really are doing an amazing job being at the right tables and making those connections. And you're really doing impactful work, facilitating impactful work for the people in your community. As we wrap up, I know you have a few resources that you wanted to share with listeners today. Do you want to highlight a couple of those? And we will also be sure to link them in the notes of this video.
Yeah, I want to share a couple, since we're talking about suicide prevention, I do want to share a couple anchors of hope. Uh, as we've been doing this work with veterans and making not only the VA work, but now the community work for the last 4 or 5 years, we have really women veterans from 2021 to 2022 using the age-adjusted suicide rates have decreased 24.1%, while for female non-veteran U.S. adults, suicide rates have increased. For male veterans, age-adjusted suicide rates have increased by 1.6%, while for male non-veterans U.S. adult rates have increased by 1.8. So not a big difference, but those veteran rates are increasing at just a little bit less. And this is the first time we have seen that happening. For the most part, women have historically been 50% more likely to die by suicide than their civilian counterparts. So to see this significant decrease is really incredible. Our homeless veterans with documented history of homelessness in their VA medical records saw a 19.1% reduction in suicide from 21 to 22. I mean, 19% reduction is a really huge percent. And so we're seeing that the work people are doing with veterans is making a difference. Transitioning service members, that's those service members who are going from that active or reserve service to veterans or to their veteran status, who have separated from the military in 21. The suicide rate over the next 12 months was 46.2 for 100 per 100,000 people. This was lower than for those who separated in 2020 and down from a high of 51 per 100,000 for those who separated in 2019. Younger veterans, the suicide rate for veterans aged 18 to 34 years decreased by 3.8% from 21 to 2022. Veterans with mental health conditions the long-term trend from 2001, to 2022, suicide rates fell for veterans receiving VHA care, that's the hospital healthcare system, with diagnoses of anxiety at 36.1%, depression was 34.5%, post-traumatic stress disorder was 31.6%, and alcohol use disorder was 13.7%. So having those rates falling for those who are receiving the VA care, we're showing that what we're doing is working, and we're really trying to share that out to our community providers and healthcare systems. Hoping to continue to see these trends lowering over time. Our veterans, as a historical look, have been at higher risk. So in any category, LGBTQ, female, any minority group, when you add that veteran status, they're at risk and then at risk again. And so anytime that we can reduce the rates for veterans, we're reducing the rates across the board for our community. And so I just want to keep working on those anchors of hope. And then we have the veteran crisis line. If you are a veteran, please dial 988 and then press 1. This is not just for suicides. This is a help hotline. If you're just feeling really stressed out, if you need someone to talk to, this is available 24/7. If you're in relationship distress, if you're struggling, please reach out. The VA created a new campaign called Don't Wait, Reach Out, that has it's a place to find resources. So it's available online. It's also a really wonderful resource you can find financial answers to financial questions on there. You basically go in and there's tabs, and based on the resources you're interested in, you just click on the tabs and it gives you a list of different links that you can go to for websites and answers. So it's very self-directed, and you're not interacting with anybody. And so if anybody's interested, they can kind of go in and dig around on the resources there. Also just another really great resource. And I know some of these things are going to be linked to the video. So feel free for people to just dig around in the links that are included with the podcast.
Excellent. Thank you so much for sharing those resources and all of the information that you did today. It is so important to address the issue of suicide, especially with veterans, and we're very thankful for their service always and your service to the community that you're serving in Iron Mountain. So thank you so much for being with us, Alyssa.
Thank you for having me. It's been a wonderful conversation.
It really has.
Thank you for listening to Field Notes, Insights from N2PH Alumni. For more information, visit N2PHealth.wisc.edu.